So what I'm gonna do in the next minutes is to summarize the role of MSCs as immunomodulatory cell product in the stem cell area. So I will start by some initial important issues regarding the role of MSCs in transplantation. I will cover what's the situation of MSC therapy in GVHD. It's very interesting, the information we have generated on the role of MSCs in a specific bone marrow GVHD, and I will finish with some insights on the role of extracellular vesicles from MSCs in the immunomodulatory role of these cells in the transplant setting. So as most of you know, mesenchymal stromal cells were defined by the HSCT as cells that can adhere to plastic. They have positive markers that are showed in the slide, and they are obviously negative for all the hematopoietic markers and for class 2 HLA. And they can, in vitro, differentiate into at least 3 lineages: adipocytes, osteoblasts, and chondrocytes. This is a slide when summarizing this ability to adhere to plastic, a phenotypic profile, and together with a multilineage differentiation capacity. So when you focus the role of MSCs in stem cell transplantation, the first issue is clear that the cells are the precursors of some cells of the niche, so they can help in engraftment. But they have obviously, and we will go through this, an extraordinary immune modulation ability. So for this indication, they are potentially useful for treating steroid refractory GVHD. And since they are able to release many soluble and paracrine factors, could be also of help in some complications of allogenic stem cell transplantation as hemorrhagic cystitis, and we have also used them in this setting. I will focus mostly in GVHD. An important issue that has to be considered is that when we perform an allogenic stem cell transplantation, we change the patient's hematopoietic system and immune system, but the stromal cells from the bone marrow remains of host origin. And this is important because we've seen that the stroma of patients with hematological malignancies have genomic and functional aberrations, and this is a couple of manuscripts of our group. So the first idea is that if we want to use mesenchymal stromal cells for an allogenic stem cell transplant recipient, we have to use allogenic cells from a normal healthy donor, because we cannot use the allogenic product because it has genomic aberrations. So as you can see in this slide, when you consider the effects of MSCs on the cells of the immune system, they are generally immunosuppressive. They suppress activated T cells, B cells, but also neutrophils, NK cells, and they are able to expand regulatory population as regulatory T cells and M2 macrophages. An important thing to exert this effect and to release all these immunomodulatory factors is that the MSCs needs to be activated in vivo by inflammatory signals as interferon, TNF, IL-1, etc. So this is again important. The role of MSC as a prophylaxis of GVHD has not resulted in big effect, but the role as treatment infused in an active immune inflammatory setting, the cells are more effective. And as you can see, the prophylactic trials have not worked out very well. But the thing is also complicated because depending on the stimuli, the MSCs now can do both immunomodulation and also immune activation, depending on the stimuli. So there are some toll-like receptors that are activated by infectious agents that can turn MSC into an MSC phenotype that activates T cell, although most of the stimuli drive the cell to an immunomodulatory role. So what's the situation from a clinical point of view of the role of MSCs in GVHD? You all know this is the classical Ferrara slide where the physiopathology of acute GVHD, the activation and inflammation of the recipient's tissue by conditioning and other agents, and the activation of the donor T cells, and finally the tissue damage. In this inflammatory setting, the role of MSCs is really effective, at least in phase 2 trials, and we'll see there are coming also some positive results from phase 3. So the first communication, the first patient that was treated was a child with refractory GVHD treated by Katarina, and she published this in Lancet 2004. And as you can see in the slide, this patient needed a second dose of MSCs to achieve a complete remission of the refractory GVHD. And there are a number of phase 2 trials, all of them with the same results. This is the largest one from a cooperative EVMT group, again headed by Katarina, by Beam, Andrea Bacigalupo, and many other people. And this is the main conclusion of one of the main conclusions of the results of this trial that has been reproduced in many others. This is they showed it for the first time. Those patients that achieve a complete remission with mesenchymal stromal cell therapy have a significant benefit in terms of overall survival, whereas those patients that either are partial responders or non-responders to cell therapy have a significantly lower survival. In our group, we've worked in a couple of phase 2 clinical trials. The first, the cells were used with autologous serum, but again, you see overall responses in terms of around 70%, with complete responses around 50%. We've moved during cell production from fetal calf serum to autologous serum, and currently we're using platelet lysate, although in the HOVON trial we're using fetal calf serum. And we've learned, these are the schemes we've used in our group, that sequential doses are needed to achieve a better response. And we tend to use 2 doses at the first week and then 2 additional doses. But the doses and the schemes are similar in groups, throughout different groups. In the HOVON trial, we use 2 millions per kilo every other week, 2 doses. So there are similar schemes, but the results are comparable. There's another manuscript trial that we did in Spain with third-party cells for refractory, and again, the same results that you can see, 70% responses, at least around 50% of complete responses, and again, those patients that get a complete response have a benefit in survival. So if you consider all these phase 2 trials and you pull it together, they have the same results that you can see here in these slides. Those patients that achieve a complete response get a benefit in overall survival, whereas those patients that do not well and do partial response or no response do not have this benefit in terms of survival. The key is to be able to predict which patients are going to respond. So what's the situation with phase 3 trials? There were 2 big trials from Osiris with the product Prochymal that never get published because they didn't get a good outcome of the primary endpoint of the trial. And one of the, if you get into the details of these trials of the procrimal, they included many patients with skin GVHD. And as you can see in the slide, there's no differences in terms of benefit for the cells compared to placebo for skin GVHD, and thus for the overall response. But if you looked into the details of the liver and gut, the patients with liver and gut involvement, there was significant benefit for the cells compared with the placebo. But unfortunately, the primary endpoint of the trial was overall response. So together with Vinfibe, Dieter, and other groups in Europe, we got a European program, the RED3 consortium, to perform a phase 3 trial in which we are currently involved. And the key issues of this trial is that we are only including patients with gut or liver, or both involvement without, and we have excluded all patients with only skin GVHD, and we are giving the cells comparing with a uniform placebo arm, and we will do the evaluation at day 29. So we hope that we can demonstrate with this design that the cells do better, at least for gut and liver GVHD in the second line of GVHD therapy after steroid resistance. And the last data that hasn't been published yet, but has been communicated in this year in the American Society of Blood and Marrow Transplantation meeting, are data again of the Mesoblast product that is the same that Osiris product in a pediatric series of patients, but they were not compared with a placebo arm. They were compared with historical controls, and as you can see in the slide, there's significant benefit in overall response for the group of for the treated patients, 69% overall response at day 28 compared with 45. And the mortality, again, is much lower for those who respond. And this probably may lead to the approval of this product, Restem-Cel-L, in pediatric patients in the United States, maybe later this year or in next year. So these are very positive data. This is the first phase 3 trial with positive results in this setting that has been communicated. But the important issue for the clinician that is treating a patient with steroid refractory GVHD are to know the mechanism of action or the potency and say, how can we predict which patients are going to respond? So we know that, as I mentioned before, that the cells are able to induce the expansion of regulatory T cells. But the best manuscript to get insight into the prediction of the mechanism of action of these cells is this that was published by Antonio Gallo of Francesco Sdassi group last year. And it's very interesting that they show that the rate of apoptosis of MSCs was higher in an animal model of GVHD compared with standard bone marrow transplantation or with naive cells. And some mesenchymal stromal cells, when they interact with recipient's serum, undergo apoptosis. And the interesting thing is that those patients who respond to MSC therapy has a significant percentage, significantly higher percentage of apoptotic MSCs compared to those patients that do not respond, and obviously compared to healthy donors. So this is the most predictive data communicated today that differentiate those patients that are going to respond to the cell product and those who do not respond. In the second part of my presentation, I would like to drive your attention to a relatively new concept that is bone marrow GVHD. I mentioned before at the beginning of my presentation that the stromal cells remains of host origin, and they are also a target of the donor T cells. And this concept is called bone marrow GVHD. And in an animal model of GVHD, you can see in the slide that those animals that have GVHD has lowest number of all hematopoietic population in the bone marrow, and this is probably caused by the fact that they deplete all the stromal cells from the inner bone of the osteoblastic niche. So again, this may be a cause of cytopenias in the setting of GVHD. So we have, after the transplant, by one side, the stromal damage induced by chemotherapy, and in those patients with GVHD, this concept of bone marrow GVHD. And it's clear from long time ago that the most intensive the chemotherapy, the most damage to the stroma. This was also demonstrated by our work we published long time ago. And we've noticed that both in vitro and in vivo, when we add MSCs from a healthy donor to a stromal layer or to an animal with stromal damage induced by chemotherapy, we improve the hematopoietic function both in vitro but also in vivo in these animal models. And we have seen how the mesenchymal stromal cells incorporate and locate into the inner part of the bone. So in some patients, even after stem cell transplantation, when they have a damaged stroma, even the cells from the graft can locate into the bone marrow and give a transient stromal cell chimerism. As here, and you can see in the slides, healthy MSCs can a little bit repair in an animal model this depletion of stromal cells in the bone marrow niche. For this purpose, when we, in these animal models, when we co-inject MSCs together with the CD34 positive cells in this xenotransplant setting, we get better engraftment, not only when we put our cells intrabone, but also when we put mesenchymal stromal cells, especially into the bone. They repair the osteoblastic niche, and they contribute to this immunomodulation and to the support of the hematopoietic cells. This is an interesting slide. We label MSCs with luciferase, and so we can track them by bioluminescence. And as you can see in the upper part of the slide, if you put your MSCs IV, they go into the lung and eventually they disappear. Whereas if you put your cells intrabone, they remain there for a longer time. This is one of the reasons why, because we have used sequential doses of MSCs when we put the MSCs intravenously, because they disappear from the circulation pretty soon. So I will show you now some data we have of post-transplant cytopenias, mainly in the setting of GVHD, treated with MSCs. There are some patients that develop, maybe sometimes related with acute or chronic GVHD, they develop post-transplant cytopenias with a complete donor bone marrow chimerism. And we treated them standard with immunoglobulins, steroids, even rituximab. But some of these patients that are refractory have been successfully treated with MSCs. We have a clinical trial for patients with cytopenias treated with our schema of intravenous MSCs in a sequential way of administration. And we communicated this, and we're going to publish this soon. We communicated in EBMT. So these patients with cytopenia, mostly thrombocytopenia, are able to respond to MSC administration, most of them, again, around 80% of the patients, with a mean time of 2 weeks or to reach 50,000 platelets per microliter. And again, it seems to be, although there are very few patients in this trial, it seems to be an advantage in terms of survival for those patients who respond to the therapy. So with that, I would like to end my presentation touching a little bit on the role of extracellular vesicles in this setting. You know that MSCs can exert their effects by cell-to-cell contact, but also by the release of soluble factors. But we focused in our from 2 or 3 years ago in new ways of communication of MSCs to surrounding cells. One way is the transfer of molecules by nanotubes, and the other one is the release of extracellular vesicles. These extracellular vesicles are small vesicles that can be generated either from the cell membrane or from endosomal structures. They contain microRNAs, mRNAs, or proteins, and can be, as I mentioned, released by MSCs, and can be incorporated in CD34 positive cells, in immune cells, and other surrounded cells. The advantage of the use of extracellular vesicles is that they are not subjected to the regulations that are needed for advanced therapies, because they are not cells, they are just a biologic product. They don't have theoretically a carcinogenic potential. They are very stable and easily stored for long-term use, and are able to cross the blood-brain barrier. And it's easy to immortalize MSC lineages to induce large amounts of extracellular vesicles. So we've seen how extracellular vesicles from MSCs can improve the function of CD34 positive cells. They are incorporated into the hematopoietic progenitors, as you can see either by confocal microscopy or by flow cytometry when we label with fluorescence dyes. And when we add, when we compare from the clonogenic potential in vitro of CD34 positive cells baseline compared with those that have incorporated extracellular vesicles, we see that the clonogenic potential is increased after the incorporation of these mesenchymal stromal cell-derived vesicles. And we do the same but in vivo, and we transplant CD34 positive cells in an immunocompromised animal that had incorporated MSC derived vesicles. There is a significant increase in engraftment for those cells that have incorporated the vesicles compared with baseline CD34 positive cells. So I think that there's also a field that needs to be explored, the role of the exosomes and extracellular vesicles derived from MSCs as a potential treatment for steroid refractory GVHD. And there's a paper by a German group, Cordelas, that treated such a patient, and this is a proof of concept in vivo that this strategy needs to be explored in the future. So with that, I would like to conclude that I think that MSCs have a potential therapeutic use in the allogenic stem cell transplant setting, at least for GVHD, probably to peripheral cytopenias that are related more or less with this bone marrow GVHD, and maybe in other indications. As I showed you before, the use of allogenic cells is mandatory because the cells are abnormal in hematologic patients, and obviously the immunosuppression also favors the use of allogenic cells. And I truly believe that the hematopoietic stem cell transplant setting is a very good model to get better knowledge for mechanistic insights in this area. But we have many other things that we don't know. We don't know if we can use MSCs pre-activated, modified, or in some way pre-stimulated. We don't know what's the best cell dose, the timing, the number of doses. There are some cells that develop abnormal genomic changes, and we need to really explore this. And we don't know yet, although the work by Francesco, that is very important. We need to know how to predict response, and we need to explore in the future what is the role of the vesicles in this setting. And with this, I would like to thank all the people in my department. This is the people that work both in the GMP facility and in the translational research cell therapy lab, and many other groups in which we collaborate together, both at the Spanish level and the European level. And I will finish with this slide that is the facade of the old building of Salamanca University. Dieter was here on Monday and Tuesday, and we are currently celebrating the 800th anniversary of the University of Salamanca, that is the oldest in Spain. And with that, I would like to thank you. Thank you, Dieter, again for the invitation. And that's my email, so that anyone that have any question later, I'm happy to answer any question or comment now. Happy to email me for whatever reason. Thank you very much.